Good morning. This is Felice D'Arco. I'm a pediatric neuroradiologist at Great Ormond Street Hospital in London and Evelina Children's Hospital. And this will be a lecture that I have done for the European Course of Neuroradiology, organized by the European Society of Neuroradiology, on neck embryology and anatomy. I will just show the basic anatomy, because then you will have some lecture about radiological anatomy of the neck. And I will really try to show you the basic of embryology of the neck, just what you need to understand the pathology. The part one is about embryology. That is always a very, very difficult topic, but I will try to make it very, very easy. And I try to use this website, osmosis.org, which is actually extremely helpful. And we'll start with a very important structure that is the Pteroglossal duct. Pteroglossal duct, as the name says, is a duct that goes from the thyroid to the tongue. Glossal means tongue, and is actually start from the foramen cecum, a small depression at the level of the between the anterior 2/3 and posterior 1/3 of the tongue, that goes down and down during the development. It starts to develop at the third gestational week, and then at the inferior margin of this depression, the thyroid gland develops. So there is the thyroid glands going downward, attached to this canal, to this duct, and grows grows over time, remaining attached to the pteroglossal duct, and at some point it goes caudally, so inferior to the hyoid bone. And it's very important that this is a duct that is normally on the midline, but actually below the hyoid bone, can be slightly off midline. And if you know this anatomy of the development, you will be able also to recognize slight variation of the pathology associated to the pterodactyl duct, in particular the pteroglossal duct cyst, that can be also off midline below the hyoid bone. So remember, caudally to hyoid bone going slightly off midline. And the final, as you know, a location of the thyroid is in front of the trachea. That's important to understand the pathology, and all this process start between the third and the seventh gestational week. How is the pteroglossal duct made? It is composed of epithelial and lymphoid cells, with the epithelial cell secreting mucus. And that's important because over time, in particularly till the 10th gestational week, the walls of this duct stick to each other, so this initiates the involution. By third trimester, the duct is usually completely gone, but if you do not have this involution, you have a secretion of mucus that continues in a duct that should not be there, and you develop a pteroglossal duct cyst. It's important to know, as you can see, that the cyst can develop everywhere along the duct course, from the foramen cecum of the tongue to the trachea. It is important that it can be also slightly off midline, and being a cyst that is not supposed to be there, it can develop a lot of complication, mainly inflammation, but also tumor and discharging sinus. So discharging sinus from the midline can be one clinical indication to your scan. And this is the appearance. Note here we are below the level of the hyoid muscle, at the level of the larynx, and this inflamed pteroglossal duct cyst is slightly off midline. So don't let it fool you. Also, another pathology, because I told you that there is the thyroid gland developing attached to this duct going down, you can have ectopic thyroid in everywhere along the course, like in these two nodules. This is just enhancing nodules, but if you know the embryological origin of the thyroid, you can say confidently that this is ectopic thyroid gland. This is the first embryological origin structure I want to speak about. There are hundreds and hundreds, but the most important are probably the pharyngeal arches, pouches, and cleft. Let's start with the embryo, again from osmosis.org. You have three germ layers: endoderm, ectoderm, and mesoderm. When you look at the embryo at 4 weeks, it looks not like a human, but more like a shrimp. But if you look at the cross-sectional area at that level, you will have the famous pharyngeal apparatus. The pharyngeal apparatus is made by arches, pouches internally, and cleft externally. And what you need to remember, because it's relevant for the anatomy, is that the arches are 6 arches and are made of mesoderm. And they develop between the 4th and 5th gestational age from mesoderm, and they are 6, but actually the fifth one never develops or regresses immediately. So basically you have 5 arches, and every arches of that, from every arch develops different structure. Then we have 4 cleft that are externally. Everything that is external is from ectoderm, and then internally, you have 4 pouches. Everything that is internal is endoderm. So 4 pouches, 4 clefts, and 5 arches plus 1. The fifth never develops or regresses immediately. Important, from each pharyngeal arch, you have a different region of the head and neck that develop. And I will try to show you how basically this will develop and what are the important part that develop from there. Another important thing, every arch includes artery, nerve, and cartilage that will form respectively vascularization, innervation, and bone muscles. First pharyngeal arch, what you guys need to remember is that everything that you need to chew comes from the first pharyngeal arch. And the nerve that you need to choose is the third branch, so mandibular branch of the trigeminal nerve. And then, of course, you have the bones that you need to chew. So mandible, maxilla, also zygomatic bone and temporal bone. But remember, the temporal bone is also the bone where the ear is, and the part of the incus and the malleolus develops from the first pharyngeal arch. This is very important when we put together the development from the arches and from the pouches in understanding the malformation of the ear. And of course, all the muscle for the mastication, so masticator muscles. And then we have tensor tympani, malleoloid, the anterior only belly of the digastric. But basically, the masticator muscles are the most important muscle you need to remember. So remember, posterior belly of the digastrics are from the second arch. Basically, the development of the digastric muscle is a good example of coordination between the first and the second arch. So remember, anterior belly, first arch, posterior belly, second arch. Apart from that, muscle for mastication or coming from the first arch. So remember, everything for chewing, nerve, bones, muscles from the first arch. Everything for facial expression are from the second arch. So facial nerve, you have some bones. You don't use bones from facial expression, right? But you have hyoid bones and the part of the temporal bone and the crura of the stapes developing from the second pharyngeal arch. And of course, all the facial muscle, the muscle for the facial expression. So remember, chewing, first arch, facial expression, second arch. About the ossicle, that's important. I will see you afterwards that it is very important that the first arch is about most of the part of the incus and the malleolus. The rest of the ossicles are from the second arch, in particular the stapes, the crura of the stapes, but the foot plate of the stapes develops from the internal auditory meatus, and so from the otic capsule, so develops together with the inner ear. And this is why the foot plate of the stapes develops together with the inner ear, so the malformation involves both of them, while rarely you have malformation of the inner ear and associated with malformation of the ossicles. Also, the muscle in the ear are developing from the second arch or the first arch, depending. Stapedius muscle from the second arch, the tensor tympani from the first arch, but this is less important. So useful to know what to look for in malformation of the ear, in particularly the ossicles and the external auditory canal malformation will go together, while the internal auditory canal and the stapes foot plate will go together as well. Third pharyngeal arch, your hyoid bone is partially developed from the third pharyngeal arch as well, and the glossopharyngeal nerve. So, glossopharyngeal nerve basically is the main thing you need to remember. Most important, fourth and sixth arch that are for speaking. So, laryngeal nerves, laryngeal cartilage with the muscle of the larynx, pharynx, and mouth, are all deriving for the fourth and sixth arch. And really, this is a big simplification, but as a general rule, remember that the first arch is from chewing, second arch for facial expression, third arch glossopharyngeal nerve, fourth and sixth arch for speaking. What about the cleft? Very important. The first cleft helps forming the ear, in particular the external auditory meatus and eardrum. If you have that the pharyngeal cleft do not regress completely, you will have the first branchial cleft cyst, which is very close to the ear canal. So you can explain the location of first branchial cleft and diagnose the first branchial cleft knowing the embryology. Second, third, and fourth clefts should fade away. If they don't fade away, you can have second, third, or fourth branchial cleft anomaly. Actually, third, fourth branchial cleft anomaly embryology is not very well known, but for sure the second branchial cleft anomaly, like in this case, is a cyst in the location of the second cleft. And then you have the pouch. Again, the first pouch is involved this time in the ear, but in the middle ear. So that's why middle ear come to get involves the first pouch, the first cleft, and the first arch will generate some problem in this area, will generate problem in the malformative problem in the external auditory canal, middle ear, and ossicles, but not in the inner ear, whose development is completely different. The second pharyngeal pouch developed the tonsil, and the third and fourth pouches, they have this dorsal and ventral areas. The dorsal areas develop the parathyroid, the ventral areas thymus and parafollicular thyroid gland. What does it mean? That the only thing you need to remember related to the third and fourth dorsal pouches, sorry, is that they participate in the calcium regulation. So, to summarize, pharyngeal arches are from mesoderm. They are involved in nerves, bones, muscle of the head and neck. And remember, first arch, mastication. Second arch, facial expression. Third arch, just glossopharyngeal, a bit of hyoid bone. Fourth and sixth, speaking. So laryngeal muscle, laryngeal cartilage, and laryngeal nerves. Cleft cleft are external, so ectoderm, participate to ear canal, pouches, part of the ear, and this is why middle and external ear abnormality go together, but also tonsil, parathyroid, and thyroid. In particular, the pouches are involved, endoderm, pouches are from endoderm, are involved in the regulation of calcium metabolism. So cleft, ear, pouches, ear, tonsil, parathyroid and thyroid, and regulation of calcium. What about the anatomy? I will just speak very briefly about the neck anatomy. We have a superficial cervical fascia that is basically subcutaneous soft tissue, very important because it has nerves, so neurofibromas will be in this location mostly, lymphatic vessel, and arterial vessels. So that's why, for instance, hemangioma will be also very superficial. And this in yellow is the superficial cervical fascia, which is again just fat between the skin and the deep cervical fascia that is in green. The deep cervical fascia divides the neck in radiological spaces that are different from the surgical triangles and more useful for us as radiologists. And we have three layers. So remember, superficial cervical fascia, deep cervical fascia. The deep cervical fascia is divided in three layers: superficial, middle, and deep. On top of that, you need to consider if you are supraioid compartment or infraioid compartment. Supraioid is this in red, infraioid in this in green. So let's start with the superficial layer. You can see in yellow what spaces surrounds the superficial layer. The masticator space, which is the one that derived from the first arch, parotid space, part of the carotid space that, as you can see, has also other two fascia, and part of the muscle here. So remember, masticator, parotid, and carotid, very importantly. On top of that, you see between the layers, you have some fat that form the retropharyngeal space and lateral pharyngeal space, or parapharyngeal space. Infraioid, the superficial layer of the deep cervical fascia, surrounds muscles. In particular, you can see here the strap muscles that will allow you the identification of the thyroid duct cyst, as we saw before. Remember, this fat in the infraioid here is the posterior cervical space. So supraioid, parapharyngeal, retropharyngeal space. Here, the posterior cervical space, very important for the identification of lymph node of the neck of the group 5, but I will show you in few slides. But remember the presence of posterior cervical space. Plus, middle layer of the deep cervical fascia surrounds the so-called mucosal space, or pharyngeal mucosal space, but also contributes to the carotid space. This is supraioid. Infraioid neck surrounds the thyroid and the esophagus, and the parathyroid here. So again, surrounds the so-called visceral space. So mucosal and visceral space are surrounded by the middle layer of the deep cervical fascia. Finally, in blue, the deep layer of the deep cervical fascia basically surrounding the vertebral bones and muscles. And you can see one important thing is that the muscle around the column are divided in so are called perivertebral space, so peri around the vertebra, but divided in a prevertebral component anteriorly and paraspinal component around the spinous processes, basically. So prevertebral and paraspinal are the two components of the perivertebral space. And also this layer contributes to the carotid space that is surrounded by all the layers. Remember that the deep layer of the deep cervical fascia has a small reflection called alar fascia. And alar fascia form the lateral and posterior wall of the retropharyngeal space, which is here. So this is the alar fascia, and this is the retropharyngeal space. Behind the retropharyngeal space, between the retropharyngeal space and the vertebral, there is the danger space that is here in green. This is from Radiopedia, showing how this danger space goes from the skull base to the mediastinum without separation, and is very, very dangerous, in fact, if an infective process like an abscess that develops in the retropharyngeal space invades this danger space. And why it's so important to have this distinction? Because, for instance, look at this lesion, calcium, and the MRI T2 hyperintensity is in the masticator space, coming from the first pharyngeal arch. Not aggressive. This will be typical of a venous malformation. This is another lesion centered in the masticator space, but much more aggressive with necrosis. This will be a rhabdomyosarcoma. Again, typical location is the masticator space. What about superficial location? Well, superficial location, we can have, as I told you before, in the superficial cervical fascia, some vessel and nerve. So you will have hemangioma, like in this case, or neurofibromas. Between the strap muscle, midline or slightly off midline, small cyst. This is a pteroglossal duct cyst, while retro and peripharyngeal space involvement is an abscess. If the abscess goes into the danger space, very, very dangerous, can go all the way down to the mediastinum. So this is why the knowledge of the radiological anatomy is so important. Although, as you can see in this scheme, you don't need to remember these things, but most of the abnormality can be transspatial or be in multiple space. So what you need to do, this is my tip for the diagnosis that I will expand in my workshop on differential diagnosis of neck masses in children. The first step for the differential diagnosis is probably solid versus cystic. And then you look at the space and then you look at other characteristics. Don't remember the nodes level. Craniocaudally, you distinguish supraioid compartment between hyoid bone and cricoid cartilage and below or better cranial, caudally to the cricoid cartilage. Level 1, A and B are below the mandible. Level 2 are at the level of the angle of the mandible, and 3 behind for same axial location, but below the hyoid bone and the cricoid bone. And remember, this important posterior cervical space is a fat space just laterally to the paraspinal space and posteriorly to the carotid space that uh, uh, is a fat space with nerve and a group 5 lymph node. So remember, not only the space, but also the nodal level you need to know. So in summary, basic embryology helps you understand neck malformation and congenital abnormalities. Division of neck in spaces is very important, and remember the division of the deep cervical fascia. Use supra and inferior neck as a first step, and space location is useful for the differential diagnosis, but only to some extent. Look also at the shape and the internal characteristic of the mass, and again, I will expand this in the workshop. These are my colleagues, plus Camilla, who is a radiologist in Rome, from Great Ormond Street. And again, my lectures are on YouTube if you are interested. Thank you very much, and I hope you enjoyed this short lecture. Please send any feedback, even negative feedback. If you want different kind of lecture, I'm very, very happy to change the way I record that.